All right, good. Let's get started. Well, first of all, I'm Shoaib. I'm one of the co-founders of BiteMedicine, and we're starting our Outrageous OSCEs week, where we're covering a bunch of OSCE topics for all of you. And I want to get straight into things because we have a lot to cover today. Today, we're covering cardiology and respiratory examinations, and this is the second part. We had a first part with Aaron, I think it was 2 weeks ago. We will be covering completely separate cases today. Before hopping into things, as always, if you stay for the whole lecture and fill out the feedback form at the end, you are eligible for a certificate of attendance. If you haven't received your certificates yet, please do bear with us. It takes about 1 to 2 weeks for Medigate to email them to you guys. Good. So we're joined today by Aaron, who's one of my good friends from Cambridge. He is currently an ophthalmologist, and he really is the go-to guy for OSCEs. He topped the year at Cambridge, so that's why we've brought him in for these lectures. But what we aim to cover today is, hopefully you should have some basic understanding of how to conduct the clinical examinations. We really want to go through cases of common things that are going to come up almost, with say 90 to 95% certainty that some of these cases that were discussed here will at some point come up in your OSCEs. We'll have 2 cardiovascular cases and 2 respiratory cases and take them through step by step with questions. As I said, there is quite a bit to cover, so this will last 1 hour to 1 hour and 10 minutes, and the slides have already been uploaded to bitemedicine.com/watch. The recording of this lecture hopefully will be uploaded within the next 2 or so days. And the aim of this entire week is to go through all of those common OSCE scenarios. So, as we'll go through in this lecture, there are about 5 or 6 cardiovascular cases and 5 or 6 respiratory cases that you just need to know. And we're going to do a similar thing for every one of the main specialties. And the idea is cover all of those big topics and put you in good stead for your exams. But without further ado, I am going to hand over to Aaron, who will get started with the cardiovascular lecture. Aaron, I think you're just muted, so if you unmute yourself.
Okay, perfect. Can you guys still hear me?
That's perfect, man.
Awesome. All right. Hi, guys. So I've seen most of you before. So yeah, me and Shoaib went to med school together. We were in the same year, prepared for our OSCEs together with a few of our friends. And this is part 2, as he said, of our cardio-resp kind of OSCE cases. The aim of today is basically to cover as many of the most common cases and give you kind of a structure to your revision. So we've seen this before. We'll quickly run over it, which is kind of what this whole approach is based around, which is called the retrospective approach, where we have come up with an OSCE cases list, which is very generic almost for any medical school in the world, which are common cases of stable patients that are likely to come up in your exams. We go through the viva for those cases, so what kind of signs you're likely to see, how to present all those findings clearly in terms of what are the positive findings and what's a relevant negative finding, risk factors, signs of complications, etc., etc. Typical viva questions that you could get asked in your OSCE. And then kind of going back in terms of your own kind of revision, what we recommend is after you've kind of hopefully seen some of these lectures, then going back to your examination routine and kind of finalizing it. So now I know what are the positive signs in all of these 5 or 6 cardiology cases. I know exactly what I'm looking for in all of these steps. So making your routine, using things like Geeky Medics as kind of a good base, and then practicing your routine on your friends, and then going to the ward if we ever get allowed back on placement and things like that, to try and find patients with these cases. So we're going to go over basically the viva and the presentation today, and through that you'll see some of the positive findings and the negative findings that we recommend. Awesome. Okay, so I'm going to do the first part, which is the cardiology OSCE cases. So these 5 cases on this list are what we prepared for our finals. They aren't a definitive list, but they're very common, they're very generic, and it's very easy for medical schools to kind of find these patients. They're usually very stable chronic patients. We're going to cover the ones in red. The ones in black have been covered in a previous lecture. If you haven't watched that, that's fine. I think all the recordings are available, and I've got a YouTube channel where you can see some similar stuff on those kind of cases as well. But we're going to focus on new stuff today. So mitral regurg and then chronic heart failure. Okay, so before we go into the cases, just a quick summary, how to present findings. This is for anyone who hasn't been to any previous kind of teaching sessions that we've done. We always recommend presenting in a very similar, systematic, structured way where you know what you're saying almost before you say it. So when you finish your examination routine, all you can think of is, I think this is what's going on and these are the findings. And it can be really easy to, when you get asked, okay, so present your findings, to just start listing things out and not kind of committing yourself to what you think could be going on, because you can always be guaranteed that the question you're going to get asked after you present your findings is, what's top differential, or what do you think this case is? And at that point, it's really easy to be like, I'm not really sure. So what we try and recommend is, if you have an idea, you might not be 100% sure, try your best to commit to that diagnosis or that case right at the start of your presentation. It makes you feel more comfortable right from the start, knowing, okay, I'm going to go with mitral regurg, for example, because I think that's what's going on. And now I'm just going to list my positive findings. I'm going to use this retrospective approach to talk about the relevant negative findings. You might be wrong, which is, you're going to be wrong anyway, because you're going to say mitral regurg at the end. But I think it forces you to give a better presentation. If you honestly have no idea, then at this start, then you can just say, I performed a cardiovascular examination on this patient, and then move on to my main positive findings are. And that could happen. That's completely normal. That doesn't mean you're going to give a bad presentation. But if you have an idea, I think it's nice to commit to it. So start with your introductory sentence where you try and commit to a diagnosis, then just list out all those 3 or 4 findings that you find in that case, then the relevant negative findings. And there's no real set mark scheme answer as to these are relevant negatives, these are not relevant negatives. If you can justify why it's a relevant negative, then no one's going to question you on it. For example, risk factors for cardiovascular disease, such as signs of diabetes, signs of smoking, signs of hypercholesterolemia, which are all these signs that we want to look for during our examination. If they're not there, then that's relevant, because this patient doesn't have these risk factors that would make them more likely to have chronic heart failure. If there's no signs of decompensation, so what I mean by that is, a lot of these patients, as we've talked about, have chronic conditions, and with things like, I don't know, COPD, you are going to get these patients that come into hospital 2 or 3 times a year with a kind of an acute infection and acute pneumonia. They would have signs of decompensation, such as requiring oxygen, or having pulmonary edema or peripheral edema or things like that. So if they don't have those, then that's really, really important. And you can usually see those signs from the end of the bed. Your patient's probably going to be stable. Say that they don't have any signs of these acute decompensation. It's really obvious stuff, but by putting it in there, you suddenly look like someone that's picked up on all these cues, all these clues, and managed to present it really nicely. And then any associated features, for example, some conditions like mitral regurg we'll see are associated with atrial fibrillation. And we'll talk about that in the theory today. So if it's not there, then say it. And then kind of summarize at the end, and you can say, like, with no signs of decompensation, because most of your patients are going to be stable. If they do have signs of decompensation, then you can say that. Okay, so that was a quick summary. Let's go straight onto the case, because I think that will be the most useful for you guys. So this is the first case. We've got these findings. Have a look, have a think. I've already kind of given you the diagnosis away, but today isn't about getting the diagnosis. It's about trying to present things, answer questions clearly. So we feel the pulse, it's irregularly irregular, and auscultation, we're listening and we can hear a pansystolic murmur. It's loudest at the mitral region, exacerbated on the patient lying on their left side and on held expiration, and that sound radiates to the axilla. So it's quite easy from this. Most of you will probably think, I think this is mitral regurg, but it's that's just like 5% of it. It's about now putting that into a really clear presentation. So before we do, we're just going to give you a quick MCQ just to kind of get you guys working again in terms of not forgetting that this is all about general medicine and MCQs as well, SBA papers. So what is P. mitrale? What is P. mitrale? If you haven't kind of logged into Menti, then if you go to menti.com and use this code, if you have no idea, then that's fine. But have a think, and we'll see why this is relevant. What is P. mitrale? So is it absent P waves? Is it broad notched P waves? Is it an increased PR interval, a reduced PR interval, or have we just completely made this word up? So give it a go. Give you guys about 30 more seconds. What is P. mitrale? And just put down an answer, even if you have no idea. Try and eliminate things that, you know, might not be the right answer. Okay, so 5 more seconds. Okay, so let's stop there. Okay, so most of you have gone for broad notch P waves, a few of you have gone for absent P waves, and then a few for the others. So the correct answer here is broad notch P waves. So really, really good if you got that. Let's have a look at kind of the explanation behind why that is the correct answer. So what is P. mitrale? If you knew it, then great. It is broad notch P waves, and it's a particular ECG finding, which is relevant here because it's related to mitral regurg. So this could come up in your SBA papers. And what it is, it's broad notch P waves. We'll see what the diagram looks like. And more specifically, what this is a sign of left atrial enlargement. And you're probably thinking, why is that relevant to mitral regurg in this whole case? We'll have a look at that later. This is basically the key thing, which is the association between having mitral regurg and why you often get an irregular pulse. Absent P waves is your atrial fibrillation. So that's atrial fibrillation, the sign of atrial fibrillation, whereas P. mitrale is the link between mitral regurg and atrial fibrillation. So sometimes you get absent P waves, sometimes you get broad notch P waves. Increased PR interval has nothing to do with mitral regurg. It's a sign of heart block. Reduced PR interval is not very common, and unfortunately, this is a real thing. I haven't just made it up. So, broad notch P waves is P. mitrale. You won't forget that now. Okay, so let's have a look at the theory first of all before we go into the viva. So mitral regurg, we all know, we now know, presents with a pansystolic murmur, and let's just work out what is a pansystolic murmur, because most of you won't be able to go on the wards right now because of COVID and things like that. Pan means kind of entirely or completely. So pansystolic murmur, it lasts the entire duration between S1 and S2. So S1 and S2 is our systole, and during that time is our pansystole. So the entire duration, and it doesn't change in its intensity. So for example, over here, S1 is that sound that you get when your mitral valve closes. So when the mitral valve closes, you get S1, lub-dub, our lub. And S2 is when our aortic valve closes. And the gap between there is systole, and then you get another S1, another S2, etc. And pansystolic murmur is this mitral regurg where you have a consistently intense murmur that starts and finishes throughout this entire duration. So that's your mitral regurg. That's what you're listening to. It's one kind of intensity. You'll see with kind of things like aortic stenosis, it doesn't last the entire time and it changes in its intensity. So we're just focusing on mitral regurg, you get a pansystolic murmur. Okay, so now why is mitral regurg associated with an irregular pulse? So I'll try and explain this with the anatomy of the heart, because this isn't most medical schools don't really tell you this. And I think I had learned this as an F1. So the problem in mitral regurg, so this is our heart, let's just orientate ourselves. So we've got the right and left side of the heart. We'll focus on the left side for now. So this is our left atrium. we're getting blood coming into the left atrium from our pulmonary vein. This is our mitral valve labeled number 1. Number 2 is our left ventricle, which is pumping blood all around through this aortic valve into the aorta through the rest of the body. So in mitral regurg, the fundamental problem is this mitral valve just doesn't close properly. Okay, it doesn't close properly. So when in a normal person, mitral valve closes and the left ventricle starts to contract, forces blood into the aorta through this tricuspid valve and it gets pumped everywhere. However, as we said, in mitral regurg, this mitral valve doesn't close properly. So when this left ventricle starts to contract, some of the blood goes through into the aorta, but some of it is regurgitated, as the name suggests, from the left ventricle back into the left atrium because it hasn't closed properly. So already you've got some inefficient pumping. Over time, so think many, many years of patient having mitral regurg, just mitral valve not closing properly, you suddenly get lots of regurgitation. This left atrium starts to become dilated. It starts to become dilated, a bit bigger. And over time, over many, many years, what happened is this left atrium starts to remodel, kind of becomes fibrosed, and it affects the electrical conduction through the heart. So you've got your sinoatrial node, your AV node, things like that. They all get affected as this left atrium kind of becomes remodeled, becomes fibrosed. And this is what leads to your atrial fibrillation, which is your irregular pulse. Okay, so just kind of to summarize all of that, in chronic mitral regurg, your left atrium remodels, and this affects the electrical conduction through the heart. So if anyone ever asks you in a viva, why is this patient got irregular pulse, you can say, I think this might be a complication from mitral regurg. If someone has mitral regurg for many years, it can cause remodeling of the left atrium, which can affect the electrical conduction of the heart. So you go from a regular heartbeat to an irregular pulse, which is what we've got here. So hopefully that makes sense. Just some of the theory to help you understand it. Okay, so let's now look at kind of questions we could get asked. And the most common question after our examination is to present our findings. So we use that same structure we talked about. I performed a cardiovascular examination on this patient. If we think it's mitral regurg, we go with it now, who has signs suggestive of mitral regurgitation. Then we list out our positive findings. So my main positive findings to support this are, I palpated an irregular pulse, which is suggestive of atrial fibrillation. And then moving on auscultation, I could hear normal first and second heart sounds. For example, there's no metallic heart sounds, suggest a metallic valve, with a systolic murmur between S1 and S2. So you've identified that as a systolic murmur. Now you're going to describe the murmur. So the systolic murmur was a pansystolic murmur, so it lasts the entire duration. It was heard loudest over the mitral region. It was augmented with 2 maneuvers on end expiration, with the patient lying on their left side. That just brings that closer to the front of the chest. And then it radiates to the axilla. So those are all features of mitral regurgitation. Okay. So my relevant negative findings are, and most of these are very, very generic. There are no signs of vascular risk factors. We talked about this earlier. For example, you're not seeing any tar staining on the nails. There's no tendon xanthomata, which would be a sign of hypercholesterolemia. There's no peripheral stigmata of infective endocarditis, Janeway lesions, Osler nodes. There are no scars on the chest to suggest a bypass graft or a valve replacement. And there are no signs of decompensation. So we talked about this, kind of any acute insults such as pulmonary or peripheral edema. And then just to summarize, this points towards a diagnosis of grade 3 mitral regurg complicated by atrial fibrillation. So you've really nicely put those 2 findings together. We'll talk about grading of murmurs in one of our slides, but basically you're going to see grade 3 or grade 4 in your exam. So that's your presentation. And you can see there, by using a retrospective approach, if you prepare kind of similar presentations for a lot of your cases that you think could come up, you know, when you go and do your examination routine, say you're starting and you have no idea what it is and you feel atrial fibrillation, in your head you should already be thinking, I'm edging towards this patient potentially having mitral regurg. There's no guarantee, but it just helps you think in a kind of a very logical way rather than just doing the steps of the routine. Cool. Okay, so we've done our presentation of our findings. We've done a really good presentation, hopefully. the next question they ask most likely is, what are our differentials? And when you get asked this question, even though you've done a really good presentation and you think you've got it as mitral regurg, don't forget to kind of back your answer up and say, I still think it's mitral regurg. A lot of people think, oh, they're only asking me for other differentials here. No, you want to start with the most common and kind of move down your list. And if you think it's mitral regurg, you can break it down into potential causes. And we know we love classifying. So, for example, what are the differentials here? My top differential would be mitral regurgitation. And this can be classified into acute mitral regurg or chronic mitral regurg. In my opinion, this is more likely chronic mitral regurg. Acute is going to be a very sick patient, so it's probably unlikely to be in your OSCE. And then you can give a few examples of each. So acute causes of mitral regurgitation could be an infective endocarditis, so kind of bacteria, kind of strep viridans normally sticking to that mitral valve, affecting it so it doesn't close properly, you've got mitral regurg. Or you've got rupture of the papillary muscle. So if you look quickly back to our diagram of the heart over here, the mitral valve has these kind of, I don't know what to call them, papillary muscle strings that kind of keep them working really well. In a heart attack, when you've got kind of ischemia to the heart muscle, these can get damaged. So once again, it doesn't work, it doesn't close properly. So that's all acute things, an infection or an MI. Chronic things are, you've got long-term ischemia to the left ventricle, for example, heart failure. Then the mitral valve annulus, the ring where the mitral valve sits, becomes dilated, so it just doesn't fit properly. Therefore, the valve doesn't close properly. That mitral valve ring can become calcified. So once again, it's all that mitral valve not closing properly. And then rheumatic heart disease is very common in kind of developing countries. And then you go to other differentials. So another differential could be another systolic murmur, aortic stenosis. However, you could say this would present with an ejection systolic murmur. You could go on to say it's kind of got different intensities, so crescendo then decrescendo, and this time it would radiate to the carotids. And then if you've got more time, a further differential would be tricuspid regurg, which is similar to mitral regurg. I'd expect a pansystolic murmur, but remember tricuspid valve is kind of the opposite of the mitral valve, so it's on the right side of the heart. So slightly different here features wise. It's heard loudest at the lower left sternal edge. All the right sided murmurs are augmented on inspiration, rather than the left side of murmurs, which are augmented on held expiration. But that's really, really rare. So I'd put that down quite low. These two are kind of your top differentials here. Okay, so talked about differentials, you've subclassified into potential causes. Now, what are the possible complications you could get asked of mitral regurgitation? Once again, we're trying to classify, so we could classify these as, and remember, if you look at this slide, we've only actually said three things. We've said infective endocarditis, valve, ventricular failure, and atrial fibrillation. We've only said 3 points, but just by classifying, it makes us look like we're saying more. So you'd say there are many complications from mitral regurgitation. They could be classified into complications from the valve itself. For example, the valve becoming infected by bacteria, causing infective endocarditis. And also you could get complications as a result of the mitral valve not closing properly, such as impaired outflow, which would lead to left ventricular failure, or atrial fibrillation from the left atrial remodeling. And we've talked about that already. So you're giving a really solid answer just by understanding the theory and by classifying. Okay. How are we doing for time? Okay. How would you investigate this patient? Once again, we always try and classify these in bedside, bloods, imaging, and special tests. And 1 or 2 from each is absolutely fine. 1 or 2 of each is absolutely fine. We've given you more here because you might not remember all of them, but you still give a really good answer. So I like to start with some bedside tests, basic observations, always relevant, heart rate, blood pressure, respiratory, O2 sats, because they could all go off in a patient who's acutely unwell. Do a urine dipstick, look for glycosuria, because that's one of the vascular risk factors, diabetes. I then like to do an ECG where I could see atrial fibrillation, which we've talked about, absent P waves, or P mitrale, which we talked about in the MCQ, which is these broad notch P waves you can see here. So you can see this double kind of peaking of the P wave before your QRS complex. And like we said, that is a sign of a dilated left atrium, where because of that chronic kind of left atrial filling, you get remodeling and then electrical problems. So that's our bedside test. Blood test, I like to do inflammatory markers because one of the complications of mitral regurg is infective endocarditis. I want to make sure there isn't any signs of that. And a BNP, which would be raised if there's associated heart failure. Remember, another one of the complications is your left ventricular outflow reduction. Then I'd like to go into some imaging. I like to start with a basic chest X-ray, look for the actual enlargement of the left atrium, and then also look for signs of heart failure, which are one of the complications. And you've got the A, B, C, D, E, F of heart failure, which we mentioned in previous lectures. You've got alveolar shadowing, curly B lines, cardiomegaly, upper lobe diversion, pleural effusions, and fluid in the fissures. You do not need to mention all 6 of them. 1 or 2 of them is more than enough. And then an echo, which is your gold standard test with most of your cardiovascular cases. And you can say this is the gold standard imaging test. It would allow me to both diagnose and also assess how severe the mitral regurg is. And obviously that plays a role in potentially doing valve replacements. And if you can remember, signs of severity are the regurgitant volume being more than 60 milliliters and the jet width more than 0.7 centimeters. So hopefully that makes sense as to that's the actual amount of blood being regurgitated back from that valve being open. So the more open the valve is, the more it can't close properly, the more kind of volume gets regurgitated back, the more severe your mitral regurg would be. And then finally, special tests. This is kind of a good one for any cardio case. I like to do coronary angiography, where you put some dye in, look at the kind of coronary circulation, see if there's any blockages, things like that, because most of these patients have some sort of vascular risk factors. They're going to have kind of coronary blockages as well. Okay, finally, they could ask you management if you've got really kind of far down the list. Classified conservative measures. So I like to focus on risk factor modifications, for example, smoking cessation. Medical factors, for example, if they've got associated atrial fibrillation, I like to put them on anticoagulation such as warfarin, because this would reduce their chance of clots. I like to manage their heart failure, for example, the ABD, ACE inhibitors, beta blockers, diuretics, and surgical options. So if you can talk about valve repair or valve replacement, and here are some of the indications. For example, if they get new onset AF as a complication, that would be a suggestion to consider repairing that valve if they've got those kind of severe features on echo, which we talked about. Okay, finally, grading of murmurs. So this is the Freeman and Levine grading. If you do get a murmur case, it's nice to just put that grade 3 or grade 4. It's an official thing that people use. So officially there's 6 grades. Grade 1 and grade 2 are basically not relevant. Therefore, cardiology consultants or people with like echoes who are like really looking for murmurs. Grade 5 and grade 6 are murmurs that probably won't come up in your OSCE because they're really loud murmurs that you can hear kind of even off the chest. So your stethoscope's only partially on the chest here or completely off the chest. So these kind of murmurs, they're not going to be well enough to come in your OSCE. They're going to be like on the waiting list for an urgent valve replacement. They're going to be very symptomatic. So you can be pretty sure that grade 3 or grade 4 is what you're going to get if you hear a murmur. It's a really easily kind of distinguishable feature, which is, does it have a thrill? So if you put your fingers over there and you feel kind of that vibration, it's grade 4. If you can't feel it, but you can hear a murmur, you can say it's grade 3. So in this case, grade 3 mitral regurg. Okay, that was the end of the first case. I will now quickly whiz through the second case because I'm leaving Shuaib with not as much time, but hopefully we'll be okay. So have a look at this case. These are the findings. So peripherally, we've got some tar staining here, one of the viscerous factors. We've got these small dots on the fingers, which are really difficult to see, but if you know you're looking for them, then that's great. And these are kind of finger prick marks from years and years of checking your blood glucose levels. We've got pitting edema kind of going up to the knee, probably in this case. And then moving centrally, we've got this scar on the neck, which you may or may not have seen before. If you haven't seen it before, you're probably not going to know what it is. If you have seen it, or if you see it now, you probably will never forget it. This is a scar from a carotid endarterectomy. So patients who have like high risk of strokes and things get an ultrasound of their neck. They look for the carotid artery. If there's a certain amount of blockage, more than 80%, I think, then you basically go in, scoop out all the cholesterol plaques, and then close it back up, kind of to reduce chance of clots breaking up and causing a stroke. Then auscultation, we're listening to the lungs, we've got crackles. So lots of signs here, and it can be difficult to kind of put all of this together. But if you see these signs, this is your heart failure case. There's no valve problems. We haven't been told that auscultation of the chest caused any murmurs. There's no valve replacement. There's no central kind of chest scar like a midline stenotomy. So this is almost certainly someone with lots of cardiovascular risk factors and who's probably got heart failure. So let's have a look at how we can present this. Oh, sorry, before that, let's do the question. So as per the New York classification of heart failure, what would you grade this patient? So this patient's breathless at rest. This is just an MCQ. Don't think that your OSCE case is, but patient's breathless at rest. How would you grade them according to New York classification of heart failure? Grade 1, grade 2, grade 3, grade 4, grade 5. Okay, about 5 more seconds. Okay, let's have a look. Okay, so most of you have gone for grade 4, 64%, 21% grade 5, and then a few for the others. So the correct answer here is grade 4. So kind of trick question here, and we'll see why, but correct answer is grade 4. So if we go to the explanation, here we go. So basically, there's 4 grades to New York classification of heart failure. So grade 1 is they're completely fine. They've got heart failure, but they're asymptomatic in terms of breathlessness. Grade 2, they've got shortness of breath on moderate activity, but nothing at rest. Grade 3, shortness of breath on mild activity, but not at rest. And grade 4 is the worst criteria. They're even breathless at rest. Grade 5 was a trick answer, which they could throw at you because there is no grade 5. Once you're shortness of breath at rest, there's not really more that you can go to kind of symptomatically. So the correct answer, if someone's breathless at rest, grade 4, according to the New York classification. Okay, now present these findings. Remember, we had lots of findings here. I performed a cardiovascular exam on this patient who has signs suggestive of chronic heart failure. My main positive findings are, now we're just going to list them out. We've got that tar staining, which is a sign of another vascular risk factor of smoking, finger prick marks suggesting blood glucose monitoring, diabetes. They've got the peripheral edema up to the knees. Then moving on to the neck, I noticed this vertical 6 centimeter scar on the neck along the distribution of the carotid artery, which suggests a carotid endarterectomy scar. And then listening to the chest, at the lung base, I can hear some bibasal crackles. So we've just listed our findings there. Now we look at the relevant negative findings. A lot of these have been kind of pinched from the last case, so very reproducible. There were no scars to suggest a bypass graft, no scars to suggest a valve replacement. There were normal heart sounds, which is good, no sounds, no added sounds or murmurs, and there was no peripheral stigmata of infective endocarditis. So in summary, this points towards congestive cardiac failure, and then you can add in a little bit, which is the presence of both some pulmonary edema and peripheral edema. So pulmonary edema from the bibasal crackles, the peripheral edema, which we saw, the pitting edema up to the knees, suggests an element of decompensation. So we can see here that we've not only diagnosed this patient, we've also commented that they're not completely stable. This is someone who's kind of on the decline. They've got some features that their heart isn't coping with kind of this heart failure. They're having to kind of, they're retaining the fluid basically in their lungs and peripherally. Okay, so kind of onto our viva now. What are the possible causes of heart failure? So there's loads of causes, but you don't have to mention all of them. Try and be systematic, try and classify. So you could say heart failure is when you've got inadequate cardiac output for the body's requirements, and you can classify into left-sided heart failure or right-sided heart failure. So left-sided heart failure is the left side of the heart trying to pump blood all the way around to the heart. So causes could be ischemic heart disease, so just when there's not enough blood going to that left ventricle, which is that big pumper all around the body, or valvular disease affecting the left side of valve, so your mitral valve or aortic valve. We saw in the mitral regurg case, because of mitral regurg, not as much blood goes into the aorta, therefore you can get heart failure. Then causes of right-sided heart failure are left-sided heart failure. So if you've got left-sided heart failure, all of that's going to kind of back up towards a pulmonary circulation and then back to the right side of the heart. So that's kind of one of the causes that everyone forgets. Right-sided heart failure can be secondary to left-sided heart failure. Same thing here, valvular disease. You could talk about the right-sided heart valves, and then cor pulmonale. So this is right-sided heart failure from respiratory kind of primary issues. So COPD, fibrosis, for example, or PE. So you've got left-sided into right-sided heart failure, valve problems, and then also specifically from pulmonary problems. So that's your causes of heart failure nicely classified. Then how would you investigate this patient? Once again, very similar, very reproducible. So bedside tests, you can talk about your observations. ECG, slightly different now. Now you're looking for kind of heart failure signs, so signs of left ventricular strain, which would be things like left bundle branch block. Easy to remember that. Right ventricular strain, right bundle branch block, really easy to remember. Then moving on to bloods, I like to do an FBC to look for anemia, because if you're already anemic, then you've got shortness of breath from heart failure. That's all going to be exacerbated. A BNP or your pro-BNP, these are both markers of heart failure. So they're raised in heart failure with different cutoffs. Use and ease, because if you've got kind of retained fluid, you get cardiorenal syndrome. So that use and ease kind of become raised. And then look for risk factors. So for example, HbA1c for diabetes, lipid profile to check that the patient's not got hypertriglyceridemia or cholesterol levels that are raised. Then imaging, you want to do your chest x-ray. We've talked about your A, B, C, D, E, F of heart failure. And then your echo, which is once again, diagnosis, gold standard to look for heart failure. And you're mainly looking for your left ventricular ejection fraction. So if you can say echo, great. If you can go further, talk about why it's relevant. So in the mitral case, we saw echo looking for the regurgitant volume. In this case, we're looking at the actual ejection fraction from the left ventricle. Okay, that's your investigate question. And then just to finish off, how would you manage this? We want to use a classified answer. So any management question, put that line in the top. You always want to use an MDT approach. You can put in a few people of the team, so GP, the heart failure team, and the OT. Conservative measures now, risk factor modification, stop smoking, diabetes, healthy diet, regular exercise. Medical management, so you want to start with both a beta blocker and an ACE inhibitor, so A and B, nice kind of start. And then add in loop diuretics such as furosemide if there's signs of fluid overload, which you've got here with the pulmonary edema and the peripheral edema. And then these are some extra stuff that if you can remember, then great, more for your MCQs. And then finally, surgical cases, for example, heart transplant, or if there's a long waiting list and you don't think this patient is going to survive until a heart transplant, then you can have a left ventricular assist device, which is, as I said, given to patients who are not likely to survive until their heart transplant becomes available. So just mention one or two of each of those, you'll be absolutely fine. And then just back to that question we talked about earlier, New York classification of heart failure, grade 1, no short of breath, grade 4, they're short of breath at rest, and there is no grade 5. So that was a quick whiz through of the cases that we're going to do on cardiology. As I said before, we've got a similar previous webinar where we looked at some other cases. I've kind of gone over time, but hopefully Shoaib can do his magic and cover respiratory. Shoaib, do you want to take over?
Yeah, it was really good, Aaron. Thanks, man. I'm just going to switch over to my PowerPoint slide.
And then we'll answer any questions at the end together, I think.
Yeah, okay. We'll definitely do a Q&A, both of us. Anything OSCE related, we can take questions. Right, so are you guys able to see my PowerPoint slide now? It should say respiratory examination at the top. Good stuff. So Aaron did a really comprehensive lecture on cardio just there. And if you actually look back on his part 1, we covered 2 or 3 more extra cases on cardio. And this is a list of the respiratory cases which could come up. There are a few more, but these are the main ones. So you have your surgical cases, and we went over that last time. Fibrosis, we went over last time. And then you have these remaining 4 items. Basically, just learn them, learn their presentations. And I think Aaron touched on this earlier, but what I'd advise is going into hospital, going to a respiratory ward and just asking them for every single patient with fibrosis, every single patient with bronchiectasis, etc. And then go look at their signs, examine their chests, and you will, by the end of a week, you would have mastered pretty much the whole of respiratory. If you do this for every single OSCE station, you know, over sort of 2 or 3 weeks, you can really get a good grasp of all the common cases. We have 2 cases to cover, so I want to power through them as I'm aware we're running a bit short of time. Do not post any of your answers in the chat, please. But this is the first case. So I am not going to give you any more information than what's written here. End of the bed, you have an audible wet cough. We have that there. So that's clubbing for those of you who didn't know. And we have an inhaler there. If you can't read it, it says tiotropium. So it's a tiotropium inhaler. You listen to the patient's chest and you hear coarse crackles which change on coughing and an occasional wheeze. So don't say what you think the diagnosis is, because that's going to be the next question. So just take all of this in and we will head over to the next question shortly. Okay. So what's the likely diagnosis here? We have COPD, asthma, fibrosis, bronchiectasis, or lung malignancy. So these are your common cases that can come up in OSCE. Let's have a look at what you guys think. So bronchiectasis, we have a split between bronchiectasis and COPD. I can see why there is a split, but the majority of you have gone for bronchiectasis, and you are indeed correct. So why isn't this COPD? So the patient has clubbing. Clubbing, you don't get clubbing in COPD. So that's a less likely diagnosis. Also, we would expect a prominent wheeze. The patient had wet cough and coarse crackles which change on coughing. That's very indicative of bronchiectasis. You wouldn't usually expect crackles in COPD unless they have an underlying infection. So if the patient has an underlying infection, then with COPD, you would expect crackles. Otherwise, you would not expect crackles in COPD. So bronchiectasis is definitely the most obvious diagnosis here. I mean, asthma, again, you wouldn't expect clubbing. You wouldn't really expect a wet cough or crackles. Pulmonary fibrosis is associated with fine crackles. It can be a bit difficult to tell the difference. If you can't, then the key giveaway here is the patient has a wet cough. So typically when examiners bring in bronchiectasis patients to OSCEs, they will have a sputum pot by the bedside, and that's the giveaway. So if the patient has a wet cough or has a sputum pot with all of these other findings, that's really suggestive of bronchiectasis. Pulmonary fibrosis, you have a dry cough. They do not produce sputum. And again, malignancy doesn't quite fit with the presentation here for the reasons explained there. So again, when it comes to your presentation, as Aaron said, if you know the diagnosis or you have an idea as to what it might be, then I would say commit to it. So I performed a respiratory examination on this gentleman who had signs of bronchiectasis. List your positive findings. So he had an audible productive cough at the end of the bedside. I also noted a long-acting antimuscarinic inhaler at the bedside. He had evidence of digital clubbing, and on auscultation, I heard coarse crepitations that altered on coughing. So typically in OSCEs, I normally categorize the medications into their, what they are. So if I saw tiotropium in an OSCE situation, I would call that an antimuscarinic inhaler. Or if I saw salbutamol, I would call that a beta agonist inhaler. That's typically what's done in OSCEs. If you don't know what the category is, then just say what the medication is. So if you didn't know tiotropium was antimuscarinic, just say, I spotted a tiotropium inhaler at the bedside. Good, so again, it's simple. When you're going through the examination, list your positive findings in the presentation, then you list your relevant negative findings, and this is pretty much going to be the same for every single respiratory examination you do. So you can just learn this and recite it off at the end of your presentation. You know, your patient's never going to be requiring oxygen in an OSCE. They're never going to have a CO2 retention flap, because if they had either of those two things, they should be in hospital. And then you can say there's no signs of decompensation, such as cor pulmonale. And always at the end of your presentation, summarize your key points. So in summary, this all points towards a diagnosis of bronchiectasis, and you always want to take it one step further. So you don't just want to stop at the diagnosis. You want to show the examiner that you've been thinking about possible causes. So you want to say to the examiner, okay, look, I think it's bronchiectasis, but when I examined this patient, there were no evident signs of an underlying cause. Therefore, the commonest causes of bronchiectasis are either idiopathic or post-infection. So I suspect those are the two most likely causes in this patient. If you spotted a sign which suggests the underlying cause, mention it. If you didn't, then I would just mention the most likely causes. So in this case, idiopathic and post-infection. And that will really impress your examiner because not many students will go beyond a diagnosis of bronchiectasis. 54% of you knew it was bronchiectasis, but the sort of top decile candidates will go beyond that and state an underlying reason for why the patient has presented like this. Again, if you don't know, then don't worry about it. It's not a big deal. This is more the bonus points. It's not going to be the pass-fail factor. So going into some theory, what is bronchiectasis? I mean, I didn't quite understand this at the beginning of my med school career, but in brief, all it is airway dilatation. So you have chronic inflammation of the airways, they become dilated and get clogged up with mucus. Because all of your lower airways get clogged up with mucus, you have the coarse crepitations, okay? Because all your alveoli and bronchioles are full with mucus. When you take a big breath in and those airways open up, they produce a crackling, a coarse crackling sound. And that's all bronchiectasis is. The other thing is they, of course, have a wet, productive cough. And that's because of all the mucus that's clogged up in their airways. So it's always useful to relate the pathophysiology to the presentation of the patient. Next question. I'll try and get some of your questions in the chat as you are answering this. So the examiner tells you the patient's heart is on the right. What is the likely underlying cause? So this actually came up in Cambridge finals. That's why I put this in here. This is a realistic case. So someone's asked a good question here. How do you decide on what negative finding to focus on? As I said, the negative findings will almost be the same for every single case that you're presented with. So just, you know, your patient's never going to be on oxygen and they're never going to be retaining carbon dioxide in an OSCE. So automatically, those are two negative findings that you can mention right off the bat for pretty much every single respiratory case. So just learn, have a set list that you're going to learn for every station. Okay, so we've got a split, quite a nice split there. We've got Cartagena syndrome and situs inversus. We've got, none of you went for the yellow nail syndrome. Measles and cystic fibrosis, obviously, we all appreciate are less common here. So again, as I said, this has come up in finals at Cambridge. There's one particular patient, I remember seeing them on the wards actually, who had this condition. And the answer is Cartagena syndrome. Let me explain why. So we focus on the two most common answers. What is Cartagena syndrome? It's a congenital cause of bronchiectasis, and patients also have situs inversus. So their organs are on the other side. Their liver is on the left, their spleen is on the right, their heart is on the right, and they also have bronchiectasis. So it's a syndrome which consists of bronchiectasis and situs inversus, and that's Cartagena syndrome. Why was situs inversus wrong? Because that doesn't explain the whole picture. Situs inversus is just a broad phrase which we use to describe organs being on the opposite side. Cartagena syndrome is one step beyond that, where patients have situs inversus and bronchiectasis. So situs inversus isn't quite the right answer. Yellow nail syndrome, we'll come on to this. So Yeah, I'll come on to these different causes in the next slide, I think. So when I was a medical student on the respiratory ward, I was asked by one of the registrars, name me 10 causes or 9 causes of bronchiectasis, and I could probably name about one, and that was post-infection. The best way to categorize the causes is into congenital, post-infection, and immunological dysfunction. If you categorize it like this and know 1 or 2 causes in each category, when the examiner asks you in your OSCE, what are the causes of bronchiectasis? If you categorize it like this, you'll look really impressive. So cystic fibrosis is a congenital cause, cartilaginous syndrome, primary ciliary dyskinesia, and yellow nail syndrome is extremely rare, but I know in Cambridge finals, for those of you who go to Cambridge, this has appeared in the past. And basically it's just patients have yellow nails and they have bronchiectasis. Post-infection, so measles, TB, and aspiration pneumonia are the most common causes. These cause that chronic inflammatory change which results in the airway dilation and the mucus collection. And then you have immunological dysfunction, rheumatoid arthritis, inflammatory bowel disease, and a few other bits and pieces. But as I said, just learn 2 in each category, and that's more than enough. Someone's asked, can pertussis also be a post-infective cause? Yeah, that's another good post-infective cause. So pertussis, also known as whooping cough, is a post-infective cause of bronchiectasis. Learn 2 or 3 in each category and you'll be absolutely fine. So we need to think about, your examiner might ask you, what are your differentials? So whenever you have a bronchiectasis patient, right off the bat, you can give a differential of fibrosis, okay, because they both present with crackles. But as I said, how do you differentiate between the two? The main thing is in bronchiectasis, you have a productive cough with coarse crackles. In fibrosis, you have a dry cough with fine crackles. So when you're presenting this back to the examiner and you're giving your differentials, you can say, I suspect bronchiectasis is the most common cause here. A less likely cause would be pulmonary fibrosis. However, this is less likely as this typically presents with a dry cough and fine end-inspiratory crackles. So in summary, my most likely diagnosis here is bronchiectasis. It's always good to talk the examiner through your reasoning and your thinking. This is another common question in OSCEs, and it's actually useful for you to know what are the different causes of clubbing for each particular system. So if we used respiratory, if we take respiratory here, because that's what we're focusing on, A, B, C, D, E, F. So lung abscess, bronchiectasis, cancer, definitely not COPD. So COPD does not cause clubbing. Empyema and fibrosis. So of this list, you're not going to get a patient with a lung abscess, and you're not going to get a patient with empyema because they will be too unwell. So if you go into your respiratory examination station and you see the patient has clubbing, you can be fairly sure that they either have bronchiectasis, cancer, or fibrosis. And in OSCEs, they typically like to bring patients in with bronchiectasis or fibrosis. So though, if you see your patient has clubbing in a respiratory station, you already know that the most likely diagnosis is either going to be bronchiectasis or fibrosis right off the bat. So that's why inspection is so important. A good inspection can give you the diagnosis without you even having to listen to the patient's chest. And then we have cardiology causes of clubbing and abdominal causes of clubbing, which are listed there, but I wanted to focus on the A, B, C, D, E, F causes of respiratory clubbing. So whenever the examiner asks you, how are you going to investigate this patient? Always, as Aaron did earlier, bedside, bloods, imaging, special tests, okay? Work it through in that order. The main thing in presentation is how you categorize things. And that's the brilliant thing about OSCEs, is that you don't actually need to know that much. If you have a good system of categorizing things and you don't actually know that much information, you can get full marks. And I remember one of my consultants telling me that OSCEs are sort of 10% knowledge and 90% acting. If you know what words to say, you will get the right marks. So bedside, always basic observations. In respiratory, always sputum. You always want to check the sputum in a respiratory patient. And in bronchiectasis, the most common organisms which these patients are affected with is Haemophilus and Pseudomonas. Okay, those are the two most common. You can check inflammatory markers to see if they've got any underlying infection. You can also offer to do an ABG to see if they've got any evidence of respiratory failure. Once you've done bedside and bloods, the next thing is imaging and special tests. So chest X-ray and CT thorax. On a chest X-ray, you see tram lines and ring shadows. And on a CT thorax, you see the signet ring sign. So again, another brilliant thing about OSCEs is you don't actually need to have a clue what a tram line looks like, because, I mean, they do occasionally bring out pictures of images, but on the whole, it's fairly unlikely that they're going to bring out a chest X-ray of a patient with bronchiectasis. So if you just say these words, that will look impressive to the examiner. So I'm going to do a CT thorax to look for the signet ring sign. Special tests, spirometry. Bronchiectasis is an obstructive condition, so you expect an FEV1 over FVC of less than 0.7. And you could also screen for an underlying cause. So rheumatoid factor if you think the patient has rheumatoid arthritis, immunoglobulins if you think they've got hypogammaglobulinemia, or a sweat test if you think they've got cystic fibrosis. So this will depend on what you see on examination. And these are the differences in spirometry between obstructive and restrictive disease. But the key point is an FEV1 over FVC ratio of 0.7. Okay, so this, just for your information, I mean, you don't particularly need to know this, but you know, if you're interested. So this here, hopefully you can see my pen drawing. That's a signet ring sign, okay? It looks like a ring. It's a dilated bronchiole with an associated blood vessel next to it. And that's known as the signet ring sign, and that's classical of bronchiectasis. Throughout the lung fields, you can see the bronchioles are dilated. So, you know, these segments here, the bronchioles are dilated. That's the signet ring sign, and that's classic of bronchiectasis. Good. And this is a really severe case of bronchiectasis. Again, CT thorax, you can see the bronchioles are dilated throughout the lung fields, and that is classical of this disease. Again, it's all about categorization. So when the examiner is going to ask you how are you going to treat the patient, always start off, if it's a chronic condition, say MDT approach. Right off the bat, if you say that, that's already ticked a little thing in the examiner's mind saying this student knows what he's talking about. You know, he's really done his revision and he's been on the wards. So just say, I would like to treat this patient in a multidisciplinary manner and involve the respiratory team, the general practitioner, and the occupational therapist. Just list 2 or 3, you know, people that you'd get involved. That's more than enough. And then management. So like investigation was categorized into bedside bloods, imaging, special tests. Management should always be categorized into conservative, medical, and surgical. So pulmonary rehabilitation, these are breathing exercises. Patients should be immunized against things like influenza. They are typically on bronchodilators, probably less so inhaled corticosteroids, but more bronchodilators. And that's what we saw at the beginning of the case. The patient had a tiotropium inhaler. Patients with bronchiectasis are often on long-term antibiotics because they're at risk of chest infections, usually azithromycin, and mucolytics. These are things which break up the mucus. Because remember, bronchiectasis is you having collection of lots of mucus in the airways. Mucolytics can help break up those that mucus. And finally, if the patient, you know, is fairly has fairly severe disease, you can consider surgical management with a lobectomy or a double lung transplant. The key thing is you don't necessarily need to know every single word on this slide, but what you do need to know is MDT approach, conservative, medical, surgical, and that will get you far. Okay, next case. Please don't say what the diagnosis is in the chat. Just have a look at that. Patient has a fine tremor. They have a, again, it's the same inhaler, tiotropium inhaler. They have evidence of pitting edema. You go to their chest. They have reduced cricosternal distance, hyperresonant percussion, and a global polyphonic wheeze. So now, if you all go to the chat and let me know, what's your diagnosis? I'm going to give you two choices, COPD or asthma. I'm not going to give you the patient's age here. But why are you all going for COPD? Why could this not be asthma? We have no evidence of smoking history here. Okay, so a lot of you have gone for COPD. It's interesting. The answer is COPD, and I will come on to why. Just taking the case, it's a fine tremor. Patient has that inhaler. They have pitting edema, reduced cricosternal distance, hyperresonant percussion, and a global polyphonic wheeze. Let's move on to the next question. Which of the following most suggests a diagnosis of COPD? Whoops, sorry. So do we have reduced PCO2, raised FEV1, reduced total lung capacity, an FEV1 over FVC of less than 0.8 post-bronchodilator, or a reduced transfer factor? So quite a wordy answer. But let's see what you guys think. So I know it's 6 o'clock now. Hopefully give me another 5 or 6 minutes and we'll get to the end of this case. Okay, so the answer is reduced transfer factor. Bit of a tricky one. So reduced PCO2, the PCO2 in COPD should be raised or normal, okay? It's not typically reduced. The FEV1 is normally reduced or normal. Total lung capacity is usually normal in COPD. It's reduced in fibrotic lung disease because in fibrosis, you're having reduction of lung volume. The fibrosis consumes and shrinks up the lung. So in fibrosis, you have a reduced total lung capacity. In COPD, it's typically normal. The FEV1 over FVC is less than 0.7 post-bronchodilator, not less than 0.8. So the correct answer by process of elimination is reduced transfer factor. Some of you might not know what transfer factor is, but in brief, it just looks at the diffusion rate of carbon monoxide into the blood. So if anything which impairs gas exchange, you will have a reduced transfer factor. So whether that be fibrosis, COPD, etc., they all are causes of reduced transfer factor. And again, same process as before. So I've examined this patient who I believe has signs of chronic obstructive pulmonary disease. Don't use the shorthand version in your OSCEs. Use the proper full version, chronic obstructive pulmonary disease. My main positive findings were a fine tremor suggesting beta agonist use, evidence of tar staining, a reduced cricosternal distance with hyperresonance suggesting hyperexpansion, a global polyphonic wheeze, and pitting peripheral edema suggestive of cor pulmonale. So just list your positive findings and then list your negative findings. So there's no signs of a mediastinal shift, no carbon dioxide retention flap, the patient wasn't on oxygen. This all points towards a diagnosis of chronic obstructive pulmonary disease. I suspect the most likely underlying cause is smoking. and he also had evidence of cor pulmonale. So again, you want to go beyond just saying the patient has COPD. You want to give an underlying cause for that. So in this case, of course, the most common cause is always smoking. So you can mention that. And also mention any evidence of complications, which in this case is cor pulmonale, because he had peripheral pitting edema. So what are your differentials? COPD, you can have two differentials for COPD. Either it's due to smoking or it's due to alpha-1 antitrypsin deficiency. It'll almost always be due to smoking if the patient is old. Asthma is the other differential. How do you differentiate between the two? In asthma, it's a younger patient and they may or may not be a smoker. COPD, it's an older patient and they tend to have evidence of smoking. So always look at the nails for tar staining. That's another point. It's not nicotine staining, it's tar staining, okay? So don't say nicotine staining. Nicotine doesn't stain, it's the tar that does the staining. The other thing that I wanted you guys to touch upon is in asthma, you don't use antimuscarinics, but in COPD you do. So if we go back to the case, you can see the guy had an antimuscarinic inhaler by the bedside, and that should have been a giveaway that this is not asthma. You don't usually use tiotropium in asthma. Also, heart failure is more typical of COPD, of course. But imagine you just walk into the station and you're doing your inspection. If you see a tiotropium inhaler, obviously you haven't actually looked at the patient's legs or anything, you haven't listened to their lungs. If you look by the bedside and see a tiotropium inhaler, you can, with a good amount of probability, say this is probably not asthma. So you can already rule that diagnosis out in your head. That's why inspection is so important. How should you investigate this patient? So it's all the same now. Basic obs, sputum, ECG. ECG in this case, because the patient had evidence of heart failure. So you can look for evidence of right heart failure, such as a right bundle branch block and a right axis deviation. Check the patient's inflammatory markers to screen for infection. Check the ABG to look for type 2 respiratory failure. And if the patient was on the younger side, then you can consider an alpha-1 antitrypsin level. Again, imaging special tests, it's always the same stuff we're working with. Chest X-ray, you're going to look for hyperexpansion. So mention that to your examiner. I would like to do a chest X-ray to look for hyperexpansion. And that's what hyperexpanded lungs look like. The diaphragm is flat and you can see more than 6 ribs anteriorly. Just a quick question, does this patient have a pneumothorax or not? Okay, good, so we've got a lot of no's. The patient doesn't, it can be confusing sometimes because these bits at the bottom look quite dark. That is not a pneumothorax. You can see lung markings going all the way down to the bottom if you look carefully. Yeah, and this is just breast shadowing. So this is a lady and those are the breast shadows. So it's not a pneumothorax. Do an echocardiogram to look for heart failure and spirometry to look for that obstructive pattern, FEV1 over FVC of less than 0.7. So just memorize that figure and mention it when they ask you about investigations. So we're almost at the end now. This is a tricky question, but you need to know it for your OSCEs. They can ask it in your viva. So which of the following is an indication for long-term oxygen therapy? Yes, I can see in the chat. So alpha-1 antitrypsin deficiency is a cause of COPD in young patients. Smoking is the most common cause by far. So alpha-1 antitrypsin is a protease inhibitor. It stops the proteases from essentially eating up your lung tissue. If you lack that alpha-1 antitrypsin, the proteases will start to digest your lung tissue. You'll develop emphysema. You'll develop COPD. All right, let's have a look. Okay. it's not loading the answer for some reason, but the correct answer is a PO2 of 7.2. So yeah, for some reason Menti wasn't working there, but the correct answer was a PO2 of 7.2. If the PO2 is less than 7.3, that is an indication for long-term oxygen therapy. All the other answers are not indications except pulmonary hypertension. So pulmonary hypertension with a PO2 of less than 8 is an indication, but you need to have both, okay? All the others are not indications, and you can read through those answers on the slides. Again, always MDT approach, conservative, medical, surgical. Smoking cessation, nicotine replacement, that's one of the most important management factors in COPD. Pulmonary rehabilitation, immunizations, bronchodilators and inhaled corticosteroids. You wouldn't need to know the management in depth for an OSCE, like you don't need to know the NICE criteria or the GOLD criteria specifically for your OSCE. You need to know that for your MCQs. So just saying I would use bronchodilators such as beta agonists or antimuscarinics is sufficient for your OSCE. Mucolytics to break up the mucus, long-term oxygen therapy, you need to know the indications. And in patients with severe disease, you can consider lung volume reduction or even lung transplantation. And these are indications for long-term oxygen therapy. The patient must have stopped smoking, because if they continue smoking, if a patient continues smoking and they're on long-term oxygen therapy, they're at risk of essentially blowing themselves up because they could ignite their oxygen tank. So you must make sure they're not smoking. Their PO2 has to be less than 7.3, or a PO2 of less than 8 and one of the following. So polycythemia, peripheral edema, or pulmonary hypertension. Both of these must be present. So the patient must be hypoxic and have one of these 3 things.
Perfect. Okay, so yeah, that was the end of the kind of lecture today. I hope you guys found it useful. This is just some information about BiteMedicine. They've got this question bank on their website where it talks about kind of MCQs really in detail, goes through explanation, kind of gives you keywords to look out for. So please check them out. And they've also got this online textbook, which has been written by all these guys and checked by consultants in their field. So please go check that out. So please fill in the feedback, which I think someone will put in the chat now, if that's okay. And I think me and Shuaib and Azim and Zach are around to answer any questions in the chat. I know there's quite a few, but we're happy to stick around for a while. Also, if it's okay, just please check out my YouTube channel, Aaron Kiru, and follow me on Instagram if you guys are interested in some MedEd content. I'll put it in the chat. But in terms of kind of questions, I think, how's the best way to kind of do this? I've just put my stuff in the chat. So Azim or Shuaib, do you want to, should we?
Yeah, I guess we could take some questions in the chat if there are any questions at all.
Yeah, probably the best to do it in the chat, so I can just go through the slides if anyone has any questions. And we'll do the similar kind of thing. So I think we're doing neurology on Thursday at 5 p.m. UK time. Abdo, Azim and Shuaib were doing on Friday, and then me and Shuaib were doing kind of a very high yield, kind of trying to predict kind of what your OSCE could be like. So one cardio case, one abdo case, one kind of niche case on neuro and cranial nerves. So make sure you check out the others. So, okay. So we have, hi, I have a question. What is the relationship between rheumatoid arthritis and bronchiectasis from Jeannie? So bronchiectasis, as we talked about, is the dilation of the bronchioles. You get this wet productive cough. There are many, many causes of this, one of them being rheumatoid arthritis. I'm not 100% sure, if I'm being honest, of the actual kind of pathological mechanism behind it. I think it's probably because rheumatoid arthritis is this autoimmune condition and it can cause lots of associations, but I know it causes bronchiectasis. The other thing to be aware of, which can come up in OSCEs, is even rheumatoid arthritis is commonly treated with methotrexate because it's an immunosuppressive medication. It works well to kind of reduce the symptoms of rheumatoid. Methotrexate by itself can also cause bronchiectasis. So if you have a bronchiectasis patient, really look for signs of rheumatoid. Can you explain what viva is? Sorry, I've been using this word that clearly like is very old fashioned. Viva is just the kind of questions that your examiner asks after you've kind of finished your examination, then you complete your examination. So for example, Viva could be, please present your findings, what's your most likely differential, etc., etc. Why do we look specifically for surgery scar for TB and tracheal deviation in COPD? Okay, so we'll answer the first thing first. TB is, a lot of TB is apical TB, so it affects the upper lobes of the lung. And previously, before all the really good medications came in, which is the right medications like isoniazid and the ethambutol and things, we used to do a small they used to do a small surgery where they did an upper lobe lobectomy, and you could specifically look for scars. Sometimes they're infraclavicular scars, so look around the clavicle. If you have someone, a lot of the times in my OSCE, I remember my examiner, I do the case, my examiner will like, have a look at this sign that you may have missed. What do you think that is? So just be aware of it. Tracheal deviation in COPD isn't very common. It usually comes as a result of surgeries. For example, if you do a removal of lung as part of the lung reduction surgery, the trachea is pulled towards the side where the lung has been removed. Is the AFP recording out yet? I think Azim will have to answer that.
Yes, all the webinars from last week are going to be uploaded either today or tomorrow. Sorry for the delay.
Perfect. I think Shoaib's back. I think.
Yeah, sorry about that.
You got distracted. What exactly is pulmonary rehabilitation? Do you want to do the rest ones and I'll do the cardio ones? Shoaib?
Yeah, so my chat's not quite loading, but pulmonary rehabilitation is essentially, it's just breathing exercises. So the common ones for COPD are like pursed lip breathing, teaching patients to breathe in a particular way, chest physiotherapy, teaching them ways in which they can sort of empty out their lungs with all that mucus, cough in a particular way, positional exercises. You're never going to be asked about it, just learn the words pulmonary rehabilitation. But in essence, that's what it is.
Fine. Just to let you know, I'm getting a few messages privately, I think, about notes and things. I know I put some notes up before.
Yeah, go ahead.
I will put some other stuff up throughout the week. I just haven't had time, sorry guys, but I'll put some other stuff up with you guys. And like I said, I'll put some other stuff.
Yeah, definitely.
But is it necessary to state the patient's name and date of birth in your final presentation? I don't think it is. If you know it's Mr. Jones, and it doesn't add anything. I don't know what Shoaib thinks about that.
No, I never used to do it. I mean, if the age is relevant, then I would say I examined this elderly gentleman, or maybe not say elderly because that can offend some people, but just, you know, if the age is relevant to the case, then mention their age, but the name is pretty irrelevant, I would say.
What does reduced cricosternal distance indicate? So do you want to do this?
Yeah, so it's a bit hard to demonstrate over the video, but reduced cricosternal distance suggests hyperexpansion of your lungs. So your lungs get hyperexpanded in COPD because it's an obstructive airway problem. You can't get air out of the lungs. The air gets trapped within the lungs expand, and the distance between your cricoid and your sternum gets reduced as a result. So you have a reduced cricosternal distance.
I think normally it's about 3 fingers.
Yeah, it should be 3 fingers or more. But it's reduced in anything which causes hyperexpansion. So COPD or asthma are your common ones.
Next one is having a carotid endarterectomy a risk factor for chronic heart failure? I guess carotid endarterectomy is just a sign that you've got carotid artery disease. So it's just one of the risk factors for kind of cardiovascular cases. You've got diabetes, smoking, kind of xanthelasma, xanthomata, carotid artery disease. They're all just various risk factors. I guess they could point towards heart failure, but they're not definitive for heart failure. This is the best series. Great. All right, that's nice to hear. Why is tricuspid regurg seen in IVDUs? Surely injecting the venous isn't reason enough, since there are more common cases. I think because of where the valve is located. So if you inject into the veins, which are superficial, then first of all, you're injecting, so you're creating a route for foreign particles to go in, and the tricuspid valve is the first valve that the blood or bacteria would hit if it comes from the vena cava into that right side of the body. So I think exactly more likely to get affected. Thank you. Any advice on the best resource for learning murmurs? Do you guys have anything on your website?
Yeah, so on the online textbook that we have a whole section section on murmurs, which is quite useful. But I mean, so definitely check that out. But ultimately, you need to hear the murmur, right? So I would, again, what me and Aaron used to do is go to a cardiology ward and ask the registrar, give us every mitral regurgitation, aortic stenosis patient that you have, and go listen to 5 mitral regurgitations, go listen to 5 aortic stenoses, and then you'll figure out how, the difference between the two. And I'd say that's the best way to do it.
Yeah, and unfortunately, it's one of those things that you kind of might need to cram before your exam, because you do kind of lose it. But I mean, go regularly to the wards. I would say that having someone's answered that. Perfect. Someone's asked me a question. Why doesn't COPD cause clubbing? I don't know if there's a reason why it doesn't cause clubbing, but it definitely doesn't cause clubbing. Is that?
I'm not sure why either. Just trying to think. Typically, like immune complex deficit. So there's a few reasons for clubbing. One of them is immune complex deposition. So you would get that in things like infective endocarditis. Others are like chronic hypoxia. So you would think that COPD would cause clubbing, but it doesn't. I'm not sure why, to be honest. I'll try and look into that and get back to you guys in the next presentation.
Then we've got something from Stasha, which says Palag rocks, so we'll leave that. Can I ask why do you get a loud S1 in mitral stenosis and a soft S2 in aortic stenosis? Are they not the same mechanism? So, well, the only thing I can really answer that is mitral.
So what was the question? Why did you get a loud S1 in mitral stenosis?
And a soft S2 in aortic stenosis.
So S1 is closing of your mitral valve, basically, and your tricuspid valve. So I guess in mitral stenosis, if you have very stiff valves, as they smack together, they're going to make a loud sound. So as those valves snap back and they're stiff, they're going to make a loud sound. So you get a harsh S1. In aortic stenosis, you don't always get a soft S2. So that's soft S2 is a sign of severe aortic stenosis. There's a few signs of severe aortic stenosis. Softening of the S2 is one of those. But I mean, again,
yeah, I didn't know that. So,
you particularly need to know, yeah.
I have a similar explanation on my YouTube video, but it's not to do with S2 and softening. So feedback form, please. Can one of you guys put that in the chat?
I think people
it's already in there somewhere. Pulmonary rehab, yep, done that. What is the best way to learn murmur sounds? You can't see these, right, Shoaib?
No, sorry, my chat's just jammed. I don't know why.
I see signs of inspection, for example, tar staining. Can you say with confidence that the patient is not a smoker? No, you definitely can't. Like, just because they haven't got tar staining doesn't mean they're not a smoker. They could have cleaned up their nail. Do you understand? Like, things could be different. But if you see it, comment on it. But also, if you don't see it and you think COPD, then you can say that I couldn't see any tar staining. That doesn't mean you're saying that this patient isn't a smoker, but it shows that you're thinking, I'd expect a smoker. I'd expect some sort of signs. So don't,
100%.
Definitely not COPD. Where are they, please, Aaron? Oh, I think that's the notes. So there's some cardio and resp OSCE notes on the BiteMedicine for Students Facebook page, I think, Facebook group. And
yeah.
hopefully put some stuff up over the next week. So please kind of stay tuned. And I put kind of everything in a video format, like I said, on my channel. Don't worry, it's BiteMedicine for Students.
Let's do like 2 or 3 more and then we'll wrap it up. It's getting quite late. I don't want to keep these guys too long.
I'm just going to have, are you guys specializing in these respective fields? No. So I'm actually doing eyes. And Shoaib's doing radiology at King's.
Yes, so two quite different things, I guess. But I mean, everyone goes through the OSCEs and we've all been there before quite recently. So we're up to date with things.
And anyone who goes to King's Med School, make sure you go check out Azim and Shoaib and King's. There'll be someone in the canteen. Any chance of being able to watch these videos again? Yeah, I think the guys are recording and they're going to put them up.
Yeah, so we record them and upload them to bitemedicine.com/watch. We'll do so, providing there's no technical issues in the next few days. I think, should we wrap it up there, Aaron? Is there anything else, any other burning questions that you wanted to take?
Last question. Would you typically feel for the apex beat in a respiratory examination as well? And if so, what is the rationale?
So really important to feel for the apex beat in a respiratory examination. Arguably one of the most important things to feel for, along with the trachea, because what would you be looking for is tension, like a tension pneumothorax, something that's going to push your mediastinum across. If you have a tension pneumothorax, your whole mediastinum will be shifted to one side with your apex beat and with your trachea. So you need to show the examiner, of course your patient won't have a tension pneumothorax, but you need to show your examiner that you know how to check for it. So when you are in A&E one day, when your patient does have a tension pneumothorax, you know what you're doing. So apex beat is a really important part, along with the trachea position in a respiratory examination.